first presentation is by Sara Basha, which is, and the presentation is a scoping literature reviews of mental health in Syria after 2011. Sara is a Syrian Scottish medical student at the University of Aberdeen. She is currently on Masters in Global Health and Management at the University of Aberdeen, and she plans to pursue a career in the humanitarian field relating to Syria. Sara, the floor is yours. Please join us.
Thank you. I'll just, it says that host disabled participant screen sharing.
Can I just ask the admin, please, to allow screen sharing for participants on this meeting? No, not yet?
No, not yet, sorry. Still not.
Yes, sorry about that. Let me just. Can you try again, please?
It's still not letting me.
Just give me a second, sorry.
Okay, it's let me do that now. Can you see that?
Yes, your screen is shared now. Yeah.
Okay, perfect, that's fine. Okay, so hello, my name is Sara Basha, and like we said before, I'm a medical student at the University of Aberdeen, and I'm integrating to complete a master's right now in global health and management. So I've been working with the Syrian American Medical Society on a project looking at the burden of maternal health in Syria, supervised by members of the research team, and I'm here to present what we've got so far from that today. Sorry. So just a little bit of background on maternal health in Syria. So Syria saw significant progress in a number of maternal health indicators in the 3 decades preceding the start of the conflict. For example, the maternal mortality ratio decreased from 482 deaths per 100,000 live births in 1970 to 52 deaths per 100,000 live births in 2009. However, there are still significant disparities in healthcare provision and access between different regions and socioeconomic groups at the time, and these issues have just been exacerbated by the conflict, which has decimated and fragmented the healthcare system. So healthcare services are delivered by different groups across Syria, which is split into 4 main geopolitical areas. So there's northwest Syria, the northern border region, which is under Turkish government control, the northeast of Syria, and then the central and southern Syria, which is under government control. So these different areas have been affected to different extents by the conflict, and with the deliberate attacks that have happened in healthcare facilities throughout the conflict, the impact on maternal healthcare provision is different depending on the region. These areas, however, are constantly changing, and even from the results that we have, we can see that there are some facilities that were previously under opposition-controlled areas, but are now either closed or under government-controlled areas. So this is one of SAM's maternal health facilities in Idlib that was bombed in 2019 and destroyed. So you can see kind of how devastating the effects are. So the aims of our study were to understand the burden of maternal health in Syria during the conflict, which we defined as starting in March 2011, as this is when protests began that eventually escalated to armed conflict. We also wanted to identify cesarean section trends in SAM's facilities since 2017. And so we did this by carrying out a scoping literature review of academic and grey literature relating to maternal health. We looked at academic databases such as MBase and Medline and reviewed a number of grey literature sources that you can see on the screen. We're currently analysing delivery data from SAM's health information systems, looking at cesarean section rates across all of SAM's facilities between March 2017 and July 2020. This is still in the exploratory phase, but I am going to be presenting some of the findings in this presentation today. So these are our inclusion and exclusion criteria for the literature review, and we split it up based on population of interest, intervention, outcomes, study design, study period, and language. And these were the results of our search. So initially we had 2,824 papers, but we're able to narrow that down to 21 papers that we felt were suitable for the study. So from these 21 papers, we found 4 main themes that we think describe maternal health overall. And these were cesarean sections, maternal mortality, perinatal care, and maternal age. And you can see on the screen the number of papers that commented on or had results for all of these themes. And as you can see, we had a lot of our included papers were grey literature reports. So this is the cesarean section rates that we found across Syria. So we had 11 papers that reported cesarean section rates. And from our results, the only rates that were lower than the WHO's recommended 10 to 15% were in Hasaka and Deir ez-Zor. All of the rest were higher than 15%. So the UNFPA reports cesarean section rates for activities in northern Syria at 25% and in southern Syria at 34%. Overall, across Syria in 2016, from the 14,409 births that they assisted with, 39% were delivered by cesarean section. So if we look at northwest Syria, we found cesarean section results for 2 cities, Aleppo and Etme. The Human Appeal report looks at Al-Iman Hospital in Aleppo in the first half of 2019, which had 22% cesarean section rates. The WHO 2015 report used the Health Resources and Services Availability Mapping System, or HERAMS, to review 113 public hospitals across Syria, looking at various different outcomes, including cesarean section rates, which they found to be 44% in 2015. Turkawi et al. Looks at a hospital, one of the CMS facilities in Etme, where they reviewed 730 women, and found that there was a between October and December of 2017, and found that there was a 30% cesarean section rate. So for northeast Syria, in Hasaka, one of the MSF maternal hospitals had 1,559 deliveries in 2015, and of these, 25% were cesarean sections. In the WHO 2015 report, they found that Raqqa had the highest number of deliveries in all of the region in Syria. This is thought to be because the hospital that was reviewed, it was the only public delivery facility in the region, and private services in that area are far too expensive for the locals to access, and so the demand on public services was very, very high. For Deir ez-Zor, the 0%, in that report, they found 0 cesarean sections, but overall in 2015, there was only 35 actual births reported from that area. So in Damascus, there were 7 papers that gave cesarean section rates. 2 of these looked at the rates Tawleed Hospital. So Al-Hmami et al. Looked at cesarean section rates between 2010 and 2017, and that value there, the 51%, is from 2017. Unfortunately, that paper doesn't give the number of births seen in that year. The other paper, De Jong et al., gave cesarean section rates for 2015 at the same hospital. Sharif et al. Reviewed women's files from various different clinics across Damascus in a period between January 2013 and June 2014, and then compared this to a period between August 2018 and January 2020. They found an increase in cesarean section rates from 33% to 52%. Kibaki and Khashrolian et al. Interviewed 1,206 women who accessed specifically the public services of a teaching hospital between November 2014 and April 2015, and found that there was a cesarean section rate of 16%. So the SAMS report looks at 10 facilities across Syria between September 2017 and February 2018. And they reported a cesarean section rate in north of Syria of 45%, south of Syria 39%, and in East Ghouta 41%. This facility in East Ghouta is an example of facilities that were running in opposition-controlled areas. So just after the end period of this study, this facility actually closed when the area was taken by government forces again. From the reports that we looked at, the SAMS, WHO, and Human Appeal all explained the high cesarean section rates across Syria as being due to the time-efficient nature of a cesarean section compared to vaginal deliveries. With persistent deliberate attacks on medical facilities throughout the conflict, women opt to undergo cesarean sections to spend as little time as possible in hospital to minimize risk. For maternal mortality, there were 7 papers that reported maternal mortality rate across Syria. And in this graph, the bar chart represents the results found in our review, and the line graph gives the World Bank's estimates for maternal mortality ratio in that same time period. There's, as you can see, there is significant variation between the results, but this is mainly due to the WHO's 2019 paper, which reported the same values for maternal mortality ratio as the World Bank, which are conflict adjusted and so significantly lower than the rest of the values that were reported. However, for each study, for each year that they reported a maternal mortality ratio, there was an increase year on year for the period of the conflict. Unfortunately, there's no geographical breakdown of these results, and given the lack of formal reporting, they're likely inaccurate. 7 of the papers that we found commented on perinatal care, with the majority of the information being about antenatal care. So 2 papers reported country-level data, 2 were studies in Damascus, 1 was a study in Etme, and 2 reported on the number of services run by MSF and UNFPA. So the paper by Adil Gawad et al. Gives an overall coverage of 88%, but doesn't actually define what they mean by antenatal coverage. De Jong et al. Defines antenatal coverage as at least 1 antenatal care visit, and they found a decrease in antenatal coverage between 2011 and 2015. I've put in the postnatal care coverage that De Jong et al. Includes in their paper in 2019 just for interest, but they highlight the fact that they couldn't find any data looking at perinatal care during the conflict, and this is something that we found was very limited as well in our study. So Kibaki and Khashrolian et al. Interviewed women in a teaching hospital in Damascus and found that 67.5% of them had 4 or more antenatal care visits. Rumia et al. Also looked at women in Damascus, interviewing 1,105 between January and December 2017 at the 8 largest primary care facilities in the area, and found that 79% had 5 or more antenatal care visits. Terkawi et al. Reviewed 730 women at a SEMA hospital in Etme, where 39% had no antenatal care visits, 14% met the minimum requirements for the WHO's 4 antenatal care visits, and only 4% met the WHO's minimum requirements for their ideal antenatal care visits, which includes 8 visits. If we can compare the results in Etme and Damascus, and we can see that there is significant disparities in healthcare provision and access across Syria. So there's been a growing number of adolescent pregnancies in Syria since the start of the conflict. And this is quite concerning considering the increased risk attributed to young maternal age and the suboptimal healthcare services that are currently available. So Human Appeal and SAMS report the proportion of pregnancies in under 18s in their facilities, and UNFPA indicates the number of pregnancies, pregnant women that they treated that were under 18 in 2016. This data is sparse and it's likely not generalizable out with the individual areas that were studied. But De Jong et al. Does give adolescent birth rates for Syria overall. Again, I've included the rate for 2019 because it was in the paper, so just for interest. But in 2013, they reported 70 births per 1,000 adolescent women. If we compare this to the World Bank estimates for adolescent birth rates in the UK, which are 18 per 1,000 in 2018, and globally, which were 42 per 1,000 in 2018, we can see that the rates reported by De Jong are very, very high. However, I think it's worth noting that the World Bank's estimates for adolescent birth rate in Syria in 2018 were 32 per 1,000, so considerably lower than De Jong's estimates. So I'm just going to quickly go over some of our findings from the SAMS data. However, this is still ongoing, and so the results are not complete yet. We looked at 77,746 births from all of the SAMS facilities in northwest Syria between March 2017 and July 2020. And as you can see, there has been a decrease in the proportion of women who are delivering by cesarean section from 35% in March 2017 to 23% in July in 2020. So there was a spike in cesarean section rates in March 2020, and we think that this is likely due to the increased violence in northwest Syria between December 2019 and February 2020, which caused a lot of the SAMS facilities to close. And so of the 5 remaining open, 3 were large referral hospitals that historically had higher rates of cesarean sections, and the other 2 were smaller facilities that contributed very little to the overall number of deliveries. And if we look at this graph, we can see in the box on the right-hand side, in that same time period, there was a decrease in both vaginal and vaginal deliveries and cesarean sections. However, as you can see, there's a more significant decrease in vaginal deliveries. And so therefore the proportion of cesarean sections was higher. So this spike represents an increase in the proportion of cesarean sections that were carried out, but not in the overall number of births, and that's likely due to the types of facilities that were left open. So overall, the results of our review showed that there was limited literature available on maternal health in Syria, with most of it being grey literature reports, single-center studies, and of poor quality. A lot of our results were based on country-level reporting with little consideration for regional differences, something that, as we've shown, is important. Maternal health has clearly been adversely affected by the conflict in Syria. However, better data collection is needed to give a better understanding of local population needs and allow for a tailored approach. Thank you very much for listening and having me today. And I wanted to thank the rest of the research team and the healthcare workers that are supporting SAM's data collection. These are my references from the studies that were included in this, from the papers that were included in this study, and I'm happy to share them if anyone wants them. Thank you.
Okay, thank you very much, Sara, for this interesting presentation. Our next presentation is about a randomized controlled trial that compared Rivaroxaban to Warfarin for treatment of cerebral venous thrombosis. This presentation is by Dr. Ahmad Khawam, who is a neurologist and researcher at the Faculty of Medicine in Damascus University. Dr. Ahmad wasn't able to join us today, but he sent a recorded presentation. I would like to ask Abdul Karim to kindly share it with you, and hope it works.
Good afternoon, everyone, and thanks for this opportunity. Cerebral venous thrombosis, or CVT, is uncommon but much better form of strokes, accounts for up to 1% of them, and often affects young females with an estimated incidence of 3 to 5 cases per million people a year. The pathogenesis of CVT is not clear. However, decreased venous blood flow drainage and CSF absorption may lead to elevation of intracranial pressure and parenchymal dysfunction. The diagnosis of CVT can be challenging, but it is best assessed with enhanced brain MRI and some other modalities. The standard of treatment of CVT is early anticoagulation with heparins, followed by oral anticoagulation, traditionally with warfarin. Rivaroxaban is one of the direct oral anticoagulants, and it is approved as a safe, effective, and more convenient alternative to warfarin in several clinical indications. However, Rivaroxaban has not been studied in any published RCT for cerebral venous thrombosis treatment, and this study, RWCVT, is aiming to fill this gap. RWCVT is an open-label multicenter RCT conducted at 3 tertiary public hospitals in Damascus, Syria, between September 2017 and March 2020. We evaluated all suspected CVT patients for eligibility if they had a recent confirmed symptomatic cerebral venous thrombosis and did not have any of our exclusion criteria when any of the studied drugs are either unsafe or contraindicated. All patients received low molecular weight heparin immediately after the diagnosis. Then, at a point when a patient was able to take oral medications and the lumbar tap was unlikely thereafter, we randomly assigned them using research randomizer to be either in R or W group. Patients in W group received an adjusted dose of warfarin with targeted INR between 2 and 3, while patients in R group received 20 mg Rivaroxaban once daily if they had no renal impairment, for 6 months. All conventional measures, for example acetazolamide, anticonvulsants, antibiotics, and immunosuppressants, were afforded as needed to all patients equally. The primary endpoints of RWCVT were clinical outcomes and independence, while the secondary endpoints were intracranial pressure normalization, major complications, and the necessity of dose titration. For evaluating clinical outcomes, we used a specialized scale called Sinus Venous Thrombosis Severity Scale, or SVTSS, which was designed by Einhapel et al. 1991, who performed the first clinical trial on CVT patients, comparing unfractionated heparins to placebo. But those items were somewhat vague. Thus, to avoid any subjective bias, we defined each element of the SVTSS scale as the following. Headache was scaled depending on the functional pain scale, based on tolerability and prevention of active or passive activity. A measurable definition was given to each degree of focal signs severity. considering cranial nerve deficits and how to deal with multiple focal injuries. We defined seizure as a clinical convulsive seizure, and we depended on Dorland's medical dictionary to define conscious deterioration terms. The patient's independency was evaluated by Barthel Index, which is a scale of 100 points evaluating daily living activities in 10 categories like feeding, bathing, grooming, etc. The secondary outcome measures were normalization of intracranial pressure, which was assessed directly or indirectly using fundoscopy. Major complications, either symptomatic intracranial hemorrhage or major extracranial bleeding, and the necessity of dose titration during follow-up period. We recruited 71 patients, 49 females and 22 males. The most affected sinus was the superior sagittal sinus in 2/3 of patients, followed by the transverse sinuses. About 60% of patients were considered to have provoked CVT. The most prevalent provoking risk factor was oral contraceptives, whereas the unprovoked CVT group was balanced between genders. All patients had headache, and 85% of them were considered moderate or severe. Focal signs were noticed in 2/3 of patients, most commonly hemiparesis. Seizures were evident in more than half of the patients. 3/4 of them were recurrent or status. Consciousness was altered in 45% of patients, and it deteriorated to a deep coma state in 6 of them. The mean SVT-SS score and Barthel index were 9.4 and 59.5 respectively. Objective evidence of elevated intracranial pressure was confirmed in 2/3, while intracranial hemorrhage was noticed in 1/3 on neuroimaging. The median low molecular weight heparin period was 7 days, which is significantly lower in the R group, and that led to a significant decrease in median length of stay in the hospital. During the 6 months follow-up period, 3 patients passed away at the very beginning. 7 patients were lost follow-up, 5 of them immediately after discharge, and 61 patients completed 6 months of follow-up. 5 patients decided to switch their anticoagulant. SVT-SS scores reduced. Barthel index increased. And intracranial pressure normalized. All of these measures improved consistently for both groups, and no significant differences were evident at any point during the follow-up period using either intention to treat or as treated analysis approaches. 2 major extracranial bleeding were documented in W group versus no one in R group, and none of our patients had any symptomatic intracranial hemorrhage or new thrombotic events during follow-up periods. Oral anticoagulant dose was modified 107 times in 26 patients. All of them were in Warfarin group. Finally, the majority of patients did reach total recovery except for 7 patients, mostly due to residual optic nerve deficits or chronic migraine type headache. To our knowledge, this is the first epidemiologic report about CVT from Syria. More than half of patients had one or more obvious provoking factors, which could be a good clue to suspect CVT in females, but not in males, as 2/3 of males were considered to have unprovoked CVT. Although headache was reported in all patients, 1/3 had no objective evidence of elevated intracranial pressure, which proposes another mediating mechanism taking part, particularly the trigeminal-vascular system. As far as we know, RWCVT is the first published RCT comparing Rivaroxaban to Warfarin in CVT treatment, and the two drugs appeared comparable in terms of efficacy, which is consistent with most studies comparing these two drugs in other indications. On the other hand, Rivaroxaban might be preferred clinically, as it could reduce the length of stay, no need for monitoring or dose titration, and it might have a better safety profile. Another direct oral anticoagulant, dabigatran, was recently studied and suggested as safe and effective too. Due to safety and logistic issues, RWCVT could not be blinded, and given the rarity of CVT in the community, the exact rate of complications could not be assured. In conclusion, this study showed that Rivaroxaban is a convenient and safe alternative to warfarin as a subsequent oral anticoagulant in CVT treatment.
Okay, I would like to thank Dr. Ahmad Al-Khawam for this presentation and hope that he would be able to join us in person in the future. I would like to remind all the participants that you can post any question you have to the chat box, and then we'll try to direct your questions to the presenters and have them answering them. Our last presentation on this session is titled Vaccine Coverage and Perceived Barriers to Vaccination Among Displaced Syrians in Lebanon. This presentation is by Salma Almidani. And Salma has Masters in Public Health, graduated from the Yale School of Public Health. Her research interests lie at the crossroads between infectious diseases and conflict, displacement, and refugee health. Please, Salma, the floor is yours.
Perfect, thank you. Let me just share my screen. Okay, perfect. So hello all. Today I'm going to be talking about a study that I did last summer, which was part of my thesis research that I did for my master's in public health. So basically what I looked at was vaccine coverage and perceived barriers to vaccinations among displaced Syrians in Lebanon. So this is just an outline of my talk. I'm going to be talking about some background, talking about the methods, the results, the conclusions, and some of the limitations that I faced since I did this study by myself on my own. So a bit of background, as you guys might know, Lebanon is one of the countries that hosts the most refugees since it's borders Syria. And at the time of the study, when I did it in the summer of 2019, there were estimated around 900,000 registered Syrian refugees in Lebanon. And then here is the updated map with the updated numbers. I believe this is from January of this year of 2020. But the true number is estimated to be around 1.5 million refugees, since many are unregistered with the UNHCR. If you take a look at the map, you could see that they're highly concentrated in Biqa, so around 38.7% of the Syrian refugees in Lebanon are concentrated in that area. There's a lot of informal tent settlements, and then obviously there's refugees that live in more urban areas. And most of this displaced population is made up of children, so around 53.3% are children. Which then leads us into why vaccine coverage is important. So because almost half of these refugees are children, and vaccinations have been proven to be the most cost-effective way to prevent outbreaks of vaccine-preventable infectious diseases. We've seen it in different conflict settings, and there's a lot of research to back that up, which is why it should be a priority, and why I really wanted to do this study. And Lebanon saw an outbreak of measles and mumps in 2013, and it just brought back a lot of concerns about formerly eradicated diseases. Same with polio. As we know, there were polio outbreaks in Syria, and that caused a lot of concern, and Lebanon responded with polio vaccine campaigns. So the reemergence of these previously eradicated diseases is a huge issue. And previous studies have shown that nationality is a factor in completing vaccinations. So Lebanese nationals had a higher odds of completing their routine vaccinations compared to Syrians. So there's previous research on how describing the disparities between the two nationalities. And then we chose to look at barriers because UNICEF found that 11% of Syrians reported financial barriers as the main barrier to accessing vaccinations. And then 10.2% reported that the vaccines weren't even available at the health centers that they visited, and 7.4% reported transportation as the main barrier to vaccination. So we just wanted to look at if there were any other barriers. We just wanted to see if this, confirmed what previous studies done, and we tried to stratify it by area. So this is what the national calendar for vaccination looks like in Lebanon. These are the vaccines that the Ministry of Public Health deems essential, and that they offer free of cost at primary healthcare centers. And while I was there, it just happened to be the 30th anniversary of their polio vaccine campaign. So 30 years ago they had started that, and now again they're facing the threat of polio because of gaps in vaccinations, and specifically in the Syrian displaced population in Lebanon. So in Lebanon, the way that vaccines are documented for children are through vaccination cards. So these cards are either provided at the primary healthcare center that you visit, or at the private clinic, or if the child is born in Lebanon, they're usually given a health record book that documents their growth and has specific designated pages for vaccinations that the parents should maintain and keep. And in order for the child to be vaccinated, they must present a vaccination card. If it's lost or the parent can't find it, they're given a new one. And so this is an example of what the vaccination card looks like. There's other pages on the inside, and what's documented is the type of vaccine given, the date, the healthcare worker that gave the vaccine, and from what I understood from the nurses that I spoke to and from the heads of the medical center, that this is an informal way of documenting it. So when they do write it, they write it in pen, and that means that the vaccine was given, and then future dates are written in pencil. So what's written in pencil is the date that the mother should bring the child back to be vaccinated. So a lot of times I would see dates written in pencil, and that just meant that the child didn't come to get vaccinated because it wasn't documented in pen. So yeah, so that's the vaccination card situation. And then in the case of many Syrian refugees, when they did flee, they didn't carry the vaccination cards with them, and new ones had to be issued. Some did have their old ones, but if they didn't have any documentation of vaccinations in Syria, the child is considered a dropout, and they are given all the essential vaccines again. It doesn't matter if the caregiver recalls that they were given a certain vaccine, unless there is the Syrian vaccination card, they will give them the vaccines again. So that's the documentation situation. And a little background about our study. So basically, we assessed vaccine coverage and barriers to vaccinations among Syrian children aged 1 to 59 months. So that's about 5 years in several regions in Lebanon. And there was also a section of the survey that looked at attitudes and beliefs surrounding vaccines, which I didn't see a lot of studies explore. And I wanted to see how this data and like how this information would play out. I'm still analyzing that part. I don't have results for it yet, but I feel like it might help inform future interventions like vaccine campaigns or awareness campaigns, and like specifically address how the Syrian displaced population in Lebanon feels or believes about vaccines. And this project was in collaboration with International Medical Corps. So it's one of the NGOs that works in Lebanon, and they specifically fund primary healthcare centers, and they reported that 56% of their primary healthcare beneficiaries were Syrians. So they were a good place to go if you wanted to speak to Syrians. And so looking at our methods, beginning with study sites, I was able to access 22 primary healthcare centers of the 50 that IMC supports in Lebanon. So 4 of those centers were in Tripoli, 5 were in Bekaa, 8 in Beirut, Mount Lebanon, 2 were 2 were in the south, and 3 were in Akkad. So Bekaa carries the highest burden, just because, like I mentioned, they have the highest number of Syrian refugees. They also have a high number of informal tent settlements. And unfortunately, I was only able to visit 5 primary healthcare centers there, just because of how remote and how distant it was from the headquarters in Beirut, and I'll talk about that more in the limitations. Same with northern Lebanon. A lot of these primary healthcare centers are remote. They're often really hard to reach and only serve a small number of beneficiaries. And a lot of these centers are independently run, so sometimes their hours like differ from day to day, and even some of them have designated vaccination days. So they'll vaccinate, for example, on Monday and Tuesday, but they won't vaccinate the rest of the day, which can be confusing when you're trying to speak to people bringing their children to get vaccinated, but I assume it'd be also confusing for people wanting to bring their children to be vaccinated. So these are some of the study sites. They're small PHCCs. A lot of them had designated vaccination rooms outside of the primary healthcare center. So the first one is in Beirut, the second one is in Bekaa, I believe, and the third one is also in Beirut. So this is just like an idea of what these PHCCs look like. And a lot of the beneficiaries were Syrian. So looking at the participants for my study, the population was Syrian refugees, obviously registered or unregistered with UNHCR. Anyone that was there utilizing primary healthcare centers supported by IMC. And just because of the time, we selected convenience sampling. And so it was anyone in that clinic with a child aged 1 to 59 months. After I arrived at the health center, I spoke to the staff, and because they had to check in, anyone coming in had to check in with the staff, they were able to direct me to who was Syrian and who was there with children that I could potentially speak to. And so that just saved the time of not having to approach Lebanese beneficiaries, since they weren't like the target population of the study. And looking at the survey, so it was administered approximately 11 weeks on site. I was the person administering it, and it's adapted from questions from the Lebanese Ministry of Public Health, from the Lebanon Country Office of the WHO, and UNICEF, combined with questions from the SAGE working group on vaccine hesitancy. And so we collected verbal responses from the survey questions, as well as documented immunization information from the people who had their vaccination cards at the time. For children who didn't have vaccination cards at the time, we basically tried to depend on the memory recall of the caregiver. So we tried to frame the questions in ways that could jog the caregiver's memory or aid them in recalling the vaccine. So we would try to ask the method that the vaccine was given in. So was it, do you remember them given drops? Do you remember an injection in the thigh? And we would try to match that up with the approximate age the child should have been given that vaccine, just to try to minimize any like false information or bad memory recall. And so the survey had 4 sections, and it was a total of 70 questions, in addition to the immunization chart that we had to fill out. So the first set of questions was about the child's immunization status, and we asked that of the parent or caretaker. The second questions assessed the barriers that they were facing when they tried to receive vaccinations, and we asked that for each vaccine. And if the child was not vaccinated, we asked why. We asked them to report that. And the third set of questions, we tried to address the beliefs and attitudes the caregiver had about vaccines and immunizations. So like an example would be, we asked about the influence of media. We asked if they were approached by NGOs for vaccine awareness sessions. We asked about culture, their trust in the health system, who makes the decisions for vaccinations was another question. And yeah, we just tried to assess their general attitudes and beliefs around this topic. And then the fourth section was demographic questions about the caretaker, place of residence, marital status, religion, and we placed this at the end of the survey just to avoid eliciting any negative reactions, and yeah, we just kept that at the end. And so some of the results, so among the surveyed children, so 1 to 59 months, 74.1% had complete vaccinations, and 25.9% were dropouts or had delayed vaccinations. And after we did the bivariate analysis, it showed that our sample had higher complete vaccinations among children aged 1 to 12 months and whose mothers had a university level education and had a knowledge of the vaccine schedule and trusted the quality of the vaccines. So those were some of the characteristics that were associated with complete vaccinations. And lower vaccination completion rates were detected among children whose mothers could only read and write or had a primary level of education. And this is pretty consistent with previous studies that showed that vaccine coverage was associated with parental education status, but in our study it was only applicable to the mothers. It wasn't really dependent on the father's educational status. And in this table, you can see some of the characteristics that we looked at. And then finally, caregivers that had their vaccine card reported higher vaccine completion at 83.2% versus 55.4%. Excuse me. And then when we looked at barriers, so the 3 main reasons for under-vaccination reported across all regions, since we stratified it by region, were the child was sick, which is 28.3%. They didn't know, they didn't remember, didn't have the motivation, basically, is 20.7%, and not trusting the quality of the vaccine was 12.3%. And not trusting the quality of the vaccine was the highest in Akkad, which is 20%, Tripoli, 19%, and Baqa, which is 14.3%. So more the high burden areas. And so some of the conclusions that we have so far is that 62.7% were able to produce vaccination cards, but for those who didn't have these cards, we had to rely on memory recall. And this just highlights the importance of good vaccine documentation and maintenance of these vaccine cards, because some were lost, some children had 2 or more vaccine cards. And in Lebanon, there's many ways of documenting and tracking these vaccinations, and it's very easy as a parent to confuse them. And so streamlining this documentation process could help reduce errors and potentially improve compliance with the vaccine schedule. And then the main reason for under-vaccination that was reported across all regions was the child was sick. And these high numbers of missed vaccinations due to sickness need to be addressed, because research has shown that mild illness should not delay vaccines. So this could be a misconception that people have. And in Biqa, 14.3% reported that the vaccine wasn't available at the health center that they went to, which was one of the original barriers that was reported in the UNICEF report. And since this high number was reported only in Biqa, I feel like it needs to be addressed. Parents could be less inclined to return their child to the vaccine center if they didn't find it the first time. And that could easily lead to the child becoming a dropout. And not trusting the quality of the vaccine was, again, the highest in Akkad, and then followed by AAA and Biqa. This potentially could be an indication of mistrust between the Syrian refugees and the Lebanese healthcare system, that they're relying on to deliver vaccines to their community. Additionally, many times this specific incident came up where they reported that during the conflict there were instances of contaminated vaccines or faulty vaccines that were administered that caused the death of children. So these could impact trust in vaccine quality even after displacement. So this could potentially be addressed. And while many other studies have looked at vaccine coverage, vaccine hesitancy has yet to be fully studied in the population or addressed, even in other countries with large Syrian refugee populations. And previous studies have shown that social factors can have an influence on vaccine hesitancy attitudes. So those could definitely be further explored. And some of the limitations that I previously talked about was because we use convenience sampling, only people who were already utilizing IMC-supported PHCCs were included in our sample. So those who weren't receiving services may have different trends. And some of these sites that I did visit were remote, they were difficult to get to, and which led to fewer surveys being collected, which could impact our results. And additionally, those without vaccination cards, we have to rely on the caregiver's memory recall, which could be inaccurate. And it's been previously shown that relying on recalls associated with incomplete or inaccurate vaccine documentation. So yeah, I'd just like to thank International Medical Corps for allowing me to do this project, and the Lebanese Ministry of Public Health and Yale School of Public Health. Thank you.
Thank you very much, Salma.